So this is Tandeka Dlamini. Today on October 28th at 1 o'clock
Central Time.
Central Time, conducting an interview for the Global Oral History of PEPFAR project via Zoom. To begin with, will you please introduce yourself, Doc? Tell us
Um,
about yourself, your family, where and when you were born, and where did you go to school?
okay, with pleasure. My name is Jean-William Pape. My friends call me Bill. I was born in Haiti. I went to school in Haiti up to baccalaureate degree 1 and 2. I went to a Catholic school. It was very important because it shaped my life. It's a school that is deeply rooted in values about ethical issues and particularly that teach you to love your country. And I think that I came back to Haiti essentially because of the schooling at that school, where they taught you to love your country, to believe in your history. And this has been very, very important to me. So that's the situation about my life in Haiti. I've been very much involved in sports. I was the captain of the volleyball team that played at the national level. So I played all sports, soccer, volleyball, ping pong, basketball, practically everything. I love sports. And I became interested in medicine very early, at the age of 12, because my uncle is a physician, and I I love to uh, be around him when he was seeing patients. And I used to see patients who were not doing well. Uh, Patients were from all strata of society, were not doing well. And then after he met them, uh, he took care of them. I saw that they were doing better. So I knew that I wanted to be involved in some form of medicine that would be transformative. Not neurology, where you make a perfect diagnosis, but you cannot change the course of the disease. And infectious disease came naturally for me because it is what was killing people in Haiti. And I've had a beautiful life, I can tell you, because I've lived to live my life the way I wanted, focusing on infectious diseases to the point that it is no longer the first cause of mortality in Haiti. It's been supplanted by cardiovascular disease, and I'm involved also now in research, training, and caring programs uh, in cardiovascular disease. So it's been really a superb experience because I witnessed how you could transform uh, public health in a country like Haiti. It has not been without challenges. I can tell you challenges have been there from day one, but I think it is what challenges, this is what makes you what you are. If you, to succeed in life, you have to face challenges and you have to meet them with confidence. As you, as you get more experience, you know how to deal with them. And now I can tell you, we are in the worst situation we were in Haiti. The country is really at the bottom, where we have 80% of the capital city where I am speaking to you right now, controlled by gangs. And those gangs, the only thing that they do is kill people, rape women, burn houses, burn businesses. Uh, 80% of health centers are not functioning in Haiti right now. It's as sad as it is. But we have developed over the years a contingency plan that has been adapted and improved after each challenge. And I can tell you that we are 100% functional. Even in that horrible environment, we are fully functional.
Hmm.
So I'll stop here. If you have any questions about my background, I am a 100% Haitian. I love my country. I love the history of my country, the way that we've been able to bring liberty to this continent. And what most people don't know is that most of Latin America has been liberated because of Haiti.
Mm. Thank you so much, Doc. Um, so I'm tempted to actually do a follow-up about your health facilities being 100% functional despite the chaos that is there. I mean, can you elaborate on that? How do you manage to do that? Because I'm sure it must be so difficult.
Well, essentially because, as I said, we have a contingency plan that
Hmm.
has been adapted, improved after each challenge. For instance, I have a fuel reserve that can last 4 months. We work very strongly with communities. I've had 32 members of my staff kidnapped, including my own son, who was kidnapped for 3 months and a half. But all our staff were freed without having to pay a dime. And I think the reason is because when it happened, I closed the facilities, and then the gangs themselves realized that it will be a big problem for them with all that population we care for without any kind of health support. So they manage themselves to free our hostages. So it has been very, very important. At one time, we had an important X-ray machine that was shipped to our place in a container, and it was kidnapped. I was really very mad about that. And then 2 hours later, I saw the truck coming back. Uh, we didn't know it was for rescue, so we brought it back. So essentially, I don't deal with gangs. I don't talk to them. But at the same time, I realize that we have a population that is very poor, that need help, and we need to provide that support. So myself, I'm not involved in politics. This is not at all my interest. My interest is in providing healthcare to the poor people of Haiti. So our global health program has been very important. It's different perhaps from other global health programs because in our situation, it had to provide many other support that is not necessary in other places. For instance, in our place, we had to provide microcredits because the people needed some kind of economic opportunity. We have a school on our campus. It's an elementary school. We also have a vocational school for rape victims. And I don't have any art talent, but I can tell you how much I appreciate the talent of our people. It's unbelievable what they can do. And we have educators from the National School of Arts that we support to train them, and they are able to do amazing things. We also have a chlorine factory that we started right after the cholera epidemic in 2010. And this cholera factory, the, the chlorine factory is providing enough potable water to a population of 400,000 people. So uh, it is really this kind of environment that we provide around us. So for us, global health cannot just be limited to health to the family. What happens when the family is no longer sick? They need to get a job. They need to provide for their kids. So, and now, as gangs have created a terrible situation where we have 1.4 internally displaced people, we are presently working in 19 camps where we are helping those people survive practically because they really have nothing. And it's a very sad story to see those people out of their home by gangs who have no other ideology than to burn, kill, and destroy.
Thank you, Doc, for that background. Um, I know that you said you had an uncle that was working in medicine when you were growing up. From the year 12 years old, you got interested into medicine. But I want to know, how did you specifically get to work on HIV issues?
Okay, so I it was usual for people in Haiti when they finish their baccalaureate degree to go and train in France. So after my 2 degrees, I went to France, and it turned out that as I was studying there, my father got very sick. He had kidney cancer. We didn't know at the time. So he was sent to Mount Sinai Hospital in New York. When I went to see him, uh, I really was uh, quite sad to see the conditions he was in. So that reinforced my desire to become a physician. But before I left for New York, my advisor in France, who had spent 1 year sabbatical at Columbia University, he said, if you want to study medicine, why don't you do it in the States? They are very advanced there. So where my uncle was saying, it was on 91st Street and Broadway, which was not far from Columbia University. And he said, why don't you go and take the entrance exam? So I went there. That was my first multiple choice exam in my life because in the French system, they usually give you essays as opposed to multiple choice. But for some reason, I did very well. I did very well in math and science in general, so I got accepted. So I did pre-med at Columbia. And what was interesting is that my advisor at Columbia, when I was applying for medical school, she said, make sure not to tell uh, during the interview that you're going to go back to Haiti, because this was my intention all along. And my first interview was at Cornell, and it went very well. We shook hands, and then at the last minute, they said, one of them said, are you planning to go back to Haiti? And I said, yes, spontaneously. And they said, can you wait a minute outside? We're going to discuss this. So I waited outside perhaps for 5 minutes, but that seemed like hours. And then they called me back with big smile and said, well, you're honest with us. We want you back if you want to stay. So I've been at Cornell ever since. When I finished medicine at Cornell, I did internal medicine training and then infectious diseases at the New York Hospital Cornell Medical Center. This is when I had a professor, Ben Keane, was a professor of tropical medicine. He was my favorite because this is what I was most interested in. He told me, what do you plan to do? I say, I plan to go back to Haiti. He said, why? You know, it's difficult there. I said, well, this is my country and I'd like to help. So he said, do you know the disease that killed the most people in your country? And I said, yes, it's infantile diarrhea. And he said, you need to develop a project on that. So I did, and I was a Rockefeller University fellow at that time. And at the same time, I integrated the Cornell program as a fellow in infectious disease. So I was a fellow in Haiti when I came back. And then I moved up the ladder from instructor to assistant professor, associate professor, full-time professor, tenure professor, etc. So I've been there all along, but my experience in Haiti was difficult but wonderful at the same time because I've been able to change so many things that it made it worthwhile.
Hmm. Interesting. So there's a lot of drive there and passion that really made you to do this kind of work clearly. So please tell us about the state of the public health in Haiti at the time when you completed your medical studies. That is
Yeah,
me.
when I came back, it was very interesting because the government was in charge of some programs. Uh, Most programs were not at all taken care of. and particularly people who were dying of infectious disease. At the time, it was infantile diarrhea for kids, tuberculosis, typhoid fever were killing adults, but infectious disease was the main driver of mortality in both adults and children. So I worked first at the largest public hospital in Haiti, which is State University Hospital in Port-au-Prince. It's a public hospital, the largest in the country, and it was fascinating because I'm not a pediatrician, I'm an internist, and I was working with children with diarrhea. As it turned out, 44% of 100 children admitted died. And what was unbelievable is that I chose infectious diseases because, in my views, we could do something. We could prevent people from dying. And then I was met with my first challenge, a lot of children coming to die. And it was horrible because there was a man coming with a big bag to pick up the bodies. And if one or two children died, he would wait because he knows that within a couple of minutes, there will be many more. So he was putting them in that huge bag before taking them to the morgue. I can tell you it was very tough for me. I didn't know if I was going to survive, but thinking about it, I said that you came here to change things. This is your first challenge. You need to meet that one. And I did some very simple things. And that's why I think public health is logic. It's really, and logic as well as wanting to change things. Because if you don't want to change things, they will always say the same. So what I realized is that in the pediatric ward, when children with diarrhea came in, they didn't give them any priority. So the child could have been there in a busy waiting room, and he would wait his turn for his turn. And in the meantime, he would have diarrhea and become dehydrated. And then when finally he was admitted, he was either dead or near dead. So what I did that was very simple, I made sure that all children who presented with diarrhea were seen first. So they gave me a room, and at that time, only IV fluids were available for rehydration. Oral rehydration did not exist. And when family was prescribed oral rehydration fluids, and then physicians were prescribing antidiarrheal drugs, antibiotics, a lot of things that were totally unnecessary. When the family, with their meager resource, came back with some of it, the child was dead. So at that time, there was no internet. I decided to go to the New York, to the Cornell Library, to see if there was something that I could do. And then with my search, I found that they were doing experiments in Bangladesh with an oral rehydration fluids for adults who had cholera. So I looked at the formula, I brought it back with me, and I applied it in Haiti. And it was the first introduction of oral rehydration. It turned out to be a huge success immediately. The only problem I had is that the adult solution had 90 milliequivalent of sodium, and the children had edema. So I cut it in half, 45 milliequivalent, and it solved the problem. So it was really beautiful to be able to tell a parent who came in with a child who was about to die, to say, look, we're going to rehydrate him. And the mother said, but he's vomiting. I said, don't worry. He never vomit everything that he absorbed. Let's be patient. Continue giving him the oral fluid. And then they can see it's like, a total revolution that it created, because The other thing I did also is that families were not admitted to stay with their children. And I needed the family to be there because I didn't have enough nurses. Sometimes I had four small kids in one bed. So by bringing the family to stay with their child, I was able to educate them. They were able to see firsthand the transformation throughout the addition fluids, and they became the best promoters. Within the first year, the mortality dropped from 44% to less than 1%. And in 1982, we developed a national program throughout the country. So we trained 14,000 people with our unit as the main training center. I used to go to each of those hospitals to see how things were going. I also had at that time a mobile team. All those things I'll be using later for AIDS, which was very interesting. So I had a mobile team that accompanied the people who were freshly trained. And also I recognize the importance of nurses, which is why later on I created the first nurse practitioner program in the country, because physicians are there once in a while, but the nurses are there all the time. So if your nurse calls you, you know it's important. So it's been a huge success. In 1982, at that time, Dr. James Grant was the head of UNICEF. He came for the inauguration. We're very, very advanced in Haiti, and this program is credited with the decrease of infantile mortality at the national level by 50%. So this was really amazing. Of course, I practically sleep there. I stayed there all the time, but it was worth it. Now, what's interesting is that as in the same hospital, as news spread that there was this formula that was able to decrease the mortality of children, I was called to see adult patients who had diarrhea in the medical ward. And those turned out to be the first AIDS cases. But at that time, the disease had no name. And when I saw them at first, I thought that it was tuberculosis, because in some of them were able to recover tuberculosis in their stools. And we treated them with TB drugs, and they got much better, but only to relapse after that and get another infection. But since I trained at Memorial Hospital in New York, because Memorial is part of the Cornell system, I realized that those patients had something related to their immunity, because many of them had Candida esophagitis that I saw very frequently with cancer patients. So I met at that time with Dr. Bernard Liotto, who's a dermatologist, and he had seen the first cases of Kaposi sarcoma. This is a disease that was totally unknown in Haiti, and he was seeing it in adult males. And then another physician, Dr. Frank Thomas, who was doing endoscopy, he said, "This is strange. I'm called to do endoscopy on a lot of patients who turned out to have Candida esophagitis. This is all new." So the three of us met together, and then we created the Haitian study group on Kaposi sarcoma and opportunistic infections, which is the acronym GESCIO in French. Haitian study group on Kaposi sarcoma and opportunistic infections, that was created on May 2nd, 1982. So it was before AIDS had a name. So since that time, we've been involved in all aspects of HIV/AIDS. First of all, we studied why Haiti and Haitians were stigmatized early on. As you may recall, the CDC put us in what they call the 4H category, which included hemophiliacs, homosexuals, heroin addicts, and then the fourth one was Haitians. Essentially, the CDC did a very poor study at that time, and they recognized it afterwards. You go and ask Haitians, "Are you homosexual?" Of course, even if they are, they'll say no. They are obviously are not hemophiliacs, So they put a label of AIDS on an entire nation. That did a lot of bad to Haiti because it destroyed our tourism completely. And I remember at some point, some professors at Cornell were asking me, they had a cook who was Haitian, whether she should be fired. Haitians were in schools in the States. They suffered a lot because they were stigmatized as the carrier of HIV/AIDS. Now, we did a study and we found that, in fact, in contrast, at that time, we had found that 65% of Haitians had risk factors comparable to what you have in the States. But early on, we had 50% were homo bisexuals, and we had 25% who had received a blood transfusion from a commercial blood bank. And at that time, there was a blood bank called Hemo-Caribbean that Haitians used to go and sell their blood, poor Haitians. And when we did studies on them, we found that a lot of them were HIV infected. But this was later when the test became available. But we were able to define the risk factors for Haitians, and we were among the first to find that heterosexual transmission was actually occurring. And we followed the transformation from a homo-bisexual population to a heterosexual population. So now it's mostly heterosexual contact. This is how HIV is transmitted here. We also did something important. We closed the commercial blood bank and put the Haitian Red Cross in charge of all blood banking operations. So this is probably the most important thing that we've done. As early on, because there was a lot of discrimination on patients with HIV, whenever we wanted to refer them for family planning, they didn't want to receive them because they had HIV. So we had to integrate this with us. When we wanted to refer them for anything, anywhere, nobody wanted them. So we integrated that service in our program. So we essentially integrated all TB, STI services, counseling. It became one large program, and we were able to take full care of our HIV/AIDS patients. We also were instrumental in preventing transmission from mother to child, and also from helping people at risk, such as homo and bisexual populations as well. So we've seen the whole gamut. We were the first to diagnose Isospora belli and Cyclospora as the early causes of diarrhea, chronic diarrhea in our patients. And we're the first to document that Trametropium sulfametoxazole bacterium was effective. And it was very, very satisfying when you could tell a patient who had chronic diarrhea for months, say, look, you're going to take those pills, in 24 hours, everything will stop. You'll be back to normal. So this was very, very good. And we conducted the first study also to show that isoniazid was instrumental in preventing HIV/AIDS patients from developing tuberculosis. And it was very interesting because at that time, AZT was coming out. We obviously didn't drive AZT because we are too poor to purchase it. But what we found is that isoniazid delayed the progress from HIV infection to AIDS. And Tony Fauci used to call it the AZT of the poor. So since that time, it took 20 years for WHO to say that this was the most cost-effective intervention for people with HIV/AIDS. So after that, we were among the first to introduce uh, antiretroviral therapy in Haiti. Now, my experience before coming to PEPFAR was very limited because the drugs were at that time costing about $22,000 a year. Obviously, we didn't have any means to provide that to our patients. But my colleagues at Cornell, when they had an AIDS patient who died, they saved all the medicine for me. So they would ship them to Haiti, and I would use them for our patients. So when the Global Fund came in, I traveled with the First Lady of Haiti to the UN at that time. We were the first recipient in 2001, and the first really to start HIV at a large scale. It was very, very satisfying. We were able to develop public health programs that were expanded to other health centers and hospitals because our mission has been research, training, and care. So it's a real program that includes all three as part of our mission. So for years, at some point, we had 51 referral centers. Now, thanks God, we have 16. But at the time, early on when we were starting, Partners in Health and GESCU, because Partners in Health was led by Paul Farmer, who was a good friend, and very much involved in the early PEPFAR program as well. So I received a phone call from Tony Fauci. This was interesting because I was going up, because I live in the mountains. Right now, I cannot go to the mountains anymore because the gangs have taken over the mountains. So I live downtown, but I was going up the mountains with my wife, and there was a huge rain. And I received a phone call. So I gave her the phone. And I said, "Can you please pick up the phone for me?" And she said, "It's Tony Fauci." So I stopped the car, and Tony said, "Bill, I need you to be on the first plane to DC." I said, "Well, that it was, I believe it was Thursday." And I said, "This weekend I'm supposed to go to Brazil because I had already a conference I was scheduled to talk to in Brazil." He said, "No, no, 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 no. It's too important. I cannot give you the details right now, but you can trust me. Jump on the first plane. I'm waiting for you there." So Tony, as you may know, was trained at Cornell as well. He's been an inspiration to me. Tremendous public health specialist and scientist. So he's been my idol, and getting that phone call, it's like as if God was calling me. And I obviously I called the people in Brazil to say that I'll be coming, instead of coming from Port-au-Prince, I'll be coming from Washington, because he said it's only a one-day meeting. And I said, I'll be one day late. They said, fine. So I jumped to the airport and went to DC. It was interesting because he said that he will not be at the meeting himself. And the people he had asked me actually how to get in touch with Paul Farmer. So I'm the one who got Paul first because he could not reach Paul. And Peter Bugini I'd never met before. So the three of us met at a restaurant where they were preparing us to how we should deal with the next day. And they said that you're going to meet people who are skeptical on whether antiretroviral therapy can be provided, and you need to convince them that it can be done. I must say that it was a huge challenge because, as you know, there were prominent scientists in the US at that time who were saying that if you provide antiretrovirals to developing countries and they don't use it properly, is going to create resistant virus, HIV virus, that's going to go to the States and travel there. Even the drug companies were somewhat reluctant to have something like that happen. So it was a huge challenge. And so the next day, we met, I believe, with Joshua Bolton. I think he was chief of staff, and he's the one who he went straight at us. Can it be done? He said, uh, I'll be honest with you, the president, we don't want to embarrass the president. Are you sure it can be done? In my experience, the people I had treated, I was convinced that it could be done. And I had treated many Haitians who had tuberculosis, and they were adherent to their treatment. So for me, it was a dream come true to be able to provide life-saving medicine to my people in Haiti. And this was something coming from the sky. And obviously, we all said the same thing. At that time, the one who had the most experience was Peter Mugini. He had treated more patients than all of us combined. But his experience was also very good. And I think I'll convince the people there that it could be given and it would be a life-changing experience.
Thank you, Doc. Very, very exciting. A lot of high moments, a lot of achievements, a lot of innovations that you've been involved in. But you're also leaving one layer that's very important. You moving from working from the government hospital and starting the NGO. We'd also like to get more information about that before we really get into the gist of your time with PEPFAR. So if that's okay.
Sure.
I'd like to backtrack you a little bit so that you can be able to tell us why did you start the NGO after working from government? It seemed like you were able to move along and have all those innovation. Why now wanting to do the NGO?
Okay. The NGO was created from day one. It was created in 1982. And at that time, which was very interesting, people working on AIDS were not well viewed by the government because AIDS was a shameful disease, and the government didn't want to be associated with AIDS. Fortunately, I had an amazing doctor who worked in public health for the government called Molière Pamphile. We were able to invite the government to be part of our group. So we are lucky that he sent us someone as respected as Dr. Pamphile, and he's been part of our group ever since. So from day one, we were linked with the government. So I didn't want the government, at that time, it was a dictatorship. I didn't want the government to think that we are doing something behind their back. Because clearly there were members in the government who didn't like us working on HIV/AIDS. So by having someone like Dr. Pamphile as part of our team, it gave us some kind of cover. Because one of our physicians who was working at University Hospital got arrested because they said he was sending pieces of patients in the States. And he was a pathologist. And when he needed to have essentially confirmation on his diagnosis, he sent it to the States to other pathologists that he used to work with for confirmation. So just to show you how mean that this could be. But having an NGO, we have two possibilities, either create a foundation or have an NGO. The NGO is what was easiest to do, and we went that way. And since the NGO has been recognized by the government as a public utility, like the Red Cross, meaning essential for the welfare of the Haitian people, and we also have support from the private sector, was created two foundations essentially to support us.
I see. So how do you get this NGO off the ground? Because if you're now operating an NGO that is different funding from federal government, who is funding you? Who helps you to set up this NGO?
Okay, essentially, the NGO was not complicated to set up. We took a lawyer and he had prepared the documents for us. We all signed the document. Now, we've been very lucky because we've been supported by the NIH continuously since 1983, uh, non-stop. As you know, those are very competitive grants. I used to apply with Cornell and GESCO as a sub. And as GESCO evolved, GESCO became the main and Cornell became the sub. So we grew up, we became adults and vaccinated, immunized after all that we have endured. And in 1991, we obtained funding from the Fogarty International Center, and that also has continued. So that has helped us train
Mm.
physician researchers, and it's been very, very important. And then when PEPFAR and the Global Fund came in, they took care of the care part. So with the NIH, mostly funding the research, uh, the training came from the Fogarty, and then the care came from Global Fund and PEPFAR. Now our funding is even more diversified. We team up with the Fondation Mérieux from France in Lyon. They've been strong supporters of our work, and they've helped us set up the school. They've helped us setting the vocational school as well, and the microcredit program. That has been very, very important. We have teamed up also with the analysis group. It's one of the largest data gathering institution in the States. They've been very, very helpful to train our staff in data analysis, in statistics, etc. So those have been our main partners. But the agreement I had with Cornell is that if a program is listed somewhere that I don't have the best at Cornell, I could do it anywhere I wanted. So since that time, we've had programs with many other universities, both in the States and in France and in Canada.
Hmm. So I just want to follow up and ask, when you're setting up GESCO, that's how you say it, right? And all this support that you're able to get from NIH, would you say that did you know Fauci at that point when you started, or was it before his time? Because I'm sure that knowing people personally or from other spaces really helps for one to be able to broker different relationships and get support in various areas. Did you know
Uh,
Fauci at that point or?
no, I didn't know Fauci at that time because he went to Cornell many years before I did. So I knew of him when I met him at the NIH, and he had invited me to speak there. And he said, by the way, I also graduated from one Cornell, etc. So that's when we started this relationship, which has been going on up to now very, very strongly. So I met also other people that I knew at Cornell, like Henri Mazur, who is the head of the National Critical Care Center. Henri was 3 years ahead of me at Cornell in infectious disease as well. So that's that's the relationship.
Hmm. So you did mention that you had a very smart strategy to co-opt the government to work with you, just so that there is that trust that is happening between the two of you. So were there other private public partnerships that you had in Haiti to be able to support this work prior to major partners as like PEPFAR and the Global Fund coming in the picture?
Yeah, what we've done, I always believe that the work is so important and so enormous that you have to invite others to work with you. And the way we work with government, and I've always done it this way, is always think of something that you'll develop with them until it becomes their idea. You have to convince them because we don't care, we don't need the maternity. All we want the work to be done. So the idea is to meet with them, tell them how important the problem is, how we're going to help them, and how they can take the credit. So it has always worked nicely. The other thing I did also, never never go to government and without your hands full of what you want. Uh, you have to essentially bring them everything and ask them to sign. You have to explain everything to them, explain how important it is for the people, and just convince them of the necessity to do this for our people. And in general, it works. Now, what I always do, I focus on one disease and one problem, not more than that. Otherwise, you give them a headache. Just focus on one thing. And then when you get that solved, you can bring another one. But don't bring, if you ask me now, I have 5 or 6 or 10 different problems that I could bring to them. But always focus on one. And this way, you have their full attention and they can also help you focus on the response. So this is the way we work with them. We also work with universities. For instance, the program we've created, the first in Haiti, first master in public health, first nurse practitioner program, we created it with Kiskia University. Kiskia University is a private university. So we did that with them, and that program is still ongoing. We work with 116 different entities, but right now, most of them are closed because of the gang situation. They are either in gang-infested area or gangs have burned or destroyed their facilities. So that's the sad situation.
Okay. So I know that you spoke a bit about establishing the first HIV voluntary counseling and testing center. That must have been a big deal because, when you come into Haiti after you trained, your major challenge was cholera, and then you had to, be involved and do all these different studies to be able to contribute towards what that kind of disease was. So then, all the evidence is there and everything else. So now you establish this center. Can you just tell us the events that led into that, I think, moment, which I think was very important because it contributed to Haiti being the first place where these studies were done and the art being one of the places where art was provided?
Well, it came naturally because obviously we were doing a lot of work. Some of them with Robert Gallo, was at the NIH at that time, to find a good test. So we tested a lot of different systems to make sure that we are dealing with HIV. We used tests. We tested the HTLV1, HTLV2, HTLV3. We did all those tests, and then Robert Gallo had another test that he wanted us to evaluate. We evaluated that test as well. So when the first HIV test came out, it was all experimental. We were part of that because very early on we were involved. So we were able in 1985 to open the first voluntary counseling and testing center in Haiti. Now, the funny part is that we're asking people for the risk factors. And obviously, nobody had wanted to admit that they had contact with sex workers, et cetera, et cetera. It was some magical thing that happened to them. Somebody set a powder on them and and they develop HIV. Now, when we talked to we had a psychologist who was very experienced. She said, you should never go against their belief. Don't tell them that AIDS cannot be transmitted by supernatural means, but tell them that it can also be transmitted this way. So by sex contact, by blood. So this way they will understand you. But if you tell them it cannot be transmitted by supernatural means, they'll close to you. And then we had all the issues of people that we had to give the diagnosis of an HIV infection. And it was horrible because at that time we could not do much. 90% of our HIV infected patients died in 1 year. We did many studies on the natural history, and we did it also in the natural history of children. And we found that it was even more devastating in children. And when we compare Haitian children with HIV in Haiti compared to HIV in Miami, those in Haiti died much sooner. And we found that it was because they were malnourished in Haiti. So malnutrition was also a contributing factor. So those things were so important that it really led us from one study into another. It's been fascinating because it never stopped. Because you ask one question, you found the answer, and that answer led you to another question. It was a never-ending story. And we got involved in vaccines. We got involved in early HIV treatment. And then we are one of the only ACTG center in the Caribbean. Even now, our retention is above 94%. Although we have all those issues that you can think of. And many of our patients live in camps, et cetera, et cetera. And I think that the recipe is to live close to your community. We have a large group of community health workers that we train. And those are the people who live with the patients. And we train them. They are essentially over multiple disease, HIV, TB, cholera, cardiovascular disease, because a lot of our work now is the cardiovascular disease. And they are the ones who bring us those patients. So they know where they live, and the community trusts them. So this is our link with the community. It's our community health agents, and we have a large group of community advisory boards. And from the poorest people in the poorest slums to everybody else that you can think of. All the religious groups are there. So it's really aimed at covering the whole slums.
I would like to have a follow-up question. If you can really try to explain in granular detail, when you were doing arts provision, like really in the early stages, how was it done? Was it within the hospital? Was it within the community? If you can just explain, because we've seen different models with the different people that were involved at the beginning. How did yours start up?
Okay, early on, we admitted our patients in the best private hospital in the country because we wanted to make sure that they were not discriminated against. So we had a whole wing of the hospital to us. It was Hôpital Canapé Vert. So we learned how to take care of patients there. And then we had built a special hospital for AIDS patients. And we found that the family would drop the patients to us and disappear. And we said, that's not the way we want it. We want the family to be part of it. So what we did is that we closed that hospital, and instead we made sure that our community health centers reached the family and made sure that the patient became central to the family. And that's when we saw that it was so important that that patient not be seen as a nuisance, but he was seen instead as a resource for the family. Because when we provided nutritional support to the patient, the family can live out of that nutritional support. When we provided job to that patient, the family live out of it. So the AIDS patients became something positive for the family as opposed to being a burden.
Interesting, Doc. Before we move to PEPFAR, I'd like to find out how many patients would you say you had treated with OT in those early stages? Can you remember the figure?
It's difficult to know. I can tell you that right now we have 16,000 patients on antiretrovirals at our centers. But early on, we are the only one treating patients in urban areas and Paul Farmer in rural areas. But most of the patients were in the urban areas. So I would say that for the first 10 years of the epidemic, Gayscure institution was treating, I would say, 60 to 70% of all patients in Haiti.
Hmm. Okay. So as you are doing all of this work, including this path-breaking, cutting-edge research on the virus, global scholars were involved in debates over clinical trials in low-resource settings. How did you manage this issue?
We are
Because you're
doing
faced with this like head on. So you're on the science part, but this is like the study site is where you're at, and you love Haiti, and you're not going to allow people to do things that are unethical. How did you manage that conflict, if I may say?
No, it was very important because very early on, 1984,
Yeah.
we created our human rights group at Gayscure. And this was the first ever created in Haiti. And this group is composed of people who are outside Gayscure, and they involve professionals, they involve people who are HIV infected, etc., etc. And that has helped us tremendously. It is through this group that we're able to create a national human rights commission in Haiti. That was created 10 years after that. And when we brought the HIV vaccine to Haiti, the requirement was to create that commission. That's when it was created, and it's still ongoing. Now, the other thing that we did, very importantly, I think that I am so at ease with ethical issues. Let me tell you why. Before we involve a patient in any research program, this is what's happened. This is the way it occurs. We have a large waiting room, and we have a social worker telling people, we have a study on this and that. Are you interested? And the people said they are interested. Then another social worker trained them on all aspects of that study. And then we have an independent psychologist who's actually asking them specific questions. For instance, for those who are involved in studies for the HIV vaccine, if they said the question was formulated as this, is the vaccine that we're going to try, do you know that if it's going to cure you? If they said yes, they are out, because they should know that it's an investigational vaccine and that we don't know at this point, etc., etc. And they need to pass with flying colors 90 out of 100. So we keep those things. So if ever a journalist is asking, are we doing something ethical? I'll just pull this and say, here, we are perhaps the only institution in the world where this is done, where before patients engage in signing a consent form, they have a full exam that shows full understanding of that particular study, how much blood that you're going to be taking, how often you're going to take it, etc., etc. So from this standpoint, I'm very, very at ease, and we publish a lot as well.
So what
So
precipitated, oh, I'm sorry. I just wanted to follow up. What precipitated your approach to doing ethical, I mean, to
well,
consider ethical issues like that? Like you're saying, you're the only institution. So why are other institutions not? And why were
well,
you adamant on that?
essentially because I know that in a poor country,
Mm.
people will be asking questions as to whether you are really inciting people to do something against their will. So we wanted people to understand and to show that Asians are altruistic as any other population.
Thank you, Doc. We've seen that Haiti had the first national strategic plan to fight HIV/AIDS in 2001. Is that correct? I just want to verify that.
That's correct. That's correct.
So, considering how long HIV/AIDS had been known to be in Haiti, and when you have a national strategic plan, it's quite a long time. Can you explain why it took such a long time, and what was the fundamental like guiding principles for the national response if there was no national plan in place for such a long time?
Well, essentially because there was no money.
Mm.
The government provided no funds. So the only time the funds came was when the Global Fund started in 2001. There was really nothing at all. And for us, we developed our public health program based on research studies that we did. So we kept adding, how do we deal with opportunistic infections? So we did the studies on Candida esophagitis, the study on chronic diarrhea, the studies on tuberculosis. And all of this added one chapter to how to deal with it.
Mhm.
So we already had a program that was easily applicable. When funding became available, we were able to extend it nationwide because we had already trained people. Because we have a training program, the Fogarty training program helped us train. I was just reviewing the data just because this interview. We've trained almost 6,000 physicians, almost 8,000 nurses, 5,000 laboratory technicians, and over 200,000 community workers. So it's a vast program. You cannot go to any health center in Haiti and not find somebody that will train. Unfortunately, with the situation that we have had for the past 6 years and the Biden program, we've lost many, many of our staff. And right now, we are really training people constantly because I don't blame them. Some of them have been displaced 4 or 5 times by gangs, and they have kids who cannot go to school because schools have been burned. So, but this is our mission. We will succeed. There is always light at the end of the tunnel. And we always believe that when there is no hope, you have to create hope.
Thank you. So out of the resources that you got from Global Fund, could you just try to delineate what kind of activities you were able to support in your programs?
Yes, essentially at that time, we knew how to treat opportunistic infections very well. We had published many, many papers on that. And we had trained people toward the country who knew how to do that. So our program consisted on all of that, except for antiretrovirals, which were not available. And that's what the PEPFAR program did. That made the difference. Because the Global Fund, at that time, we didn't have antiretrovirals.
Mhm. And then, in terms of your partnerships, I know that you had to make a deliberate effort to work with the government, the sake of ownership and making sure that you're not taking over the agenda of what the government is doing. Were there other local NGOs that you were working with, any other partners at all, or was it
Yes.
mainly guest corps and government?
Yeah, I said we work with 116 different organizations.
Okay.
Uh, PIH has been our sister institution.
Mm.
Uh, in fact, when cholera came in Haiti in 2010, we at that time it was interesting because I had tried everything by the book, and what helped was oral rehydration that I introduced early on. So you see how life turned in cycle. I didn't know that cholera. This was the first cholera epidemic in Haiti. We never had cholera before. But fortunately, the population knew how to use oral rehydration. So this was one good thing. But in spite of that, I had patients being carried on wheelbarrows who could not, were half dead when they arrived. So I tried everything that they said. I tried wash, I tried everything. And I said, why not use the oral cholera vaccine? So everybody was against it. CDC was against it. USAID was against it. PAHO was against it. The government was against it. Fortunately, I have some good friends in Washington. I went there. I explained what I wanted to do. And they say, well, you don't work in rural areas. I say, well, in rural areas, I'll bring the team of Paul Farmer. I work in urban areas, so the two of us will do it. So they gave us the chance, and we provided oral cholera vaccine. And since that time, it changed the WHO guidelines because they had never given oral cholera vaccine during an epidemic. And this vaccine has been used all over the world since that time. More than 1 million doses have been given in Africa, in Asia, essentially because the guidelines have been changed. For HIV/AIDS also, we changed many WHO guidelines based on the research conducted in the field. So with the government, it has been, I would say, not difficult to work with for a number of reasons. Because we help the government. And in fact, whenever there is an epidemic, they call on us. For instance, dengue, chikungunya, Zika, cholera, COVID. In fact, the late president, Jordan Moise, was assassinated, unfortunately, and asked me to take the lead on COVID. So I became in charge of COVID for the whole of Haiti. And we did very, very well because we had very few people died of COVID in Haiti. So we've been involved in every single disaster. After the earthquake, again, we've been very much involved, but each time we've learned. For instance, we are able to learn internally displaced people now because we had, on our own campus, we had 9,000 people who were internally displaced. So we learn how to take care of them, and we publish on that, and we can reproduce that work now for other people who are displaced due to gangs.
Okay, so we have Global Fund now, and you did say that you had some quite stable streams of funding that were supporting your work. So I just want to find out how different or similar was the Global Fund funding model, and how did you find it?
Early on, I was very, very much involved in the Global Fund. I think it was a superb experience. Uh, I work very closely with the government because most of it was run by the government, and we had to make sure that it was run properly. The only issue I had with the Global Fund was later on, when they had a recipe that fit all. And I think that this is when it created problem. For instance, they have the country coordinating mechanism, CCM. Early on, it was a restricted group of people fully interested. But when Geneva indicated you need to include this, you need to include that, etc., and when the government included them, people were not interested. They went to meetings and you saw they were sleeping, and the program lost its interest. And I think this is where PEPFAR became more adapted to the country's needs. For instance, we had a fixed formula from Geneva. The same way I had a fixed formula also for children with diarrhea. That didn't work in Haiti. I had to create my own. So I think that this is where you need to let people's imagination and people intervention have the lead way, as opposed to what you have behind your desk that you write and say that this is one formula fit every single country. So that's when the Global Fund became, I think, redundant, and it became less interesting.
Did you work with the Millennium Challenge account? Do you have any experience with them?
No, I know about it, but we didn't qualify, I guess. I think you need 20 or some parameters, but we had a dictatorship at that time. There's been corruption in Haiti, etc., etc. So I don't think we fitted the.
Okay, so let's fast forward now to the exciting events just before PEPFAR is announced. I know that you had spoken about getting that phone call when you're in the mountains from Fauci, and it tells you, summons you sort of to just get onto your first plane to DC. Did you have any idea why he was calling you? Had you had some kind of preliminary conversations about this happening? Like, I mean, in terms of PEPFAR, what went through your mind when you got that phone call?
Honestly, I had no clue. I had no clue at all. And Paul asked me, Paul had no clue. Peter Bogini had no clue. We didn't know why. But Tony is, if you want, the spiritual father of all of us. When Tony called, everybody responded because we know that it's for something good for public health. And we are glad that we did.
Mm. I see. So it was like a god when it comes to public health. I think you said that. I even noted that in my book. I was like, okay, this is where I think relationship and connections, personal connections become very important for doing things that are impactful. So can we just get into the details of what happened at this dinner when you finally all got together, yourself, Paul Farmer Mungenyi with Fauci? What were the proceedings of that meeting?
Well, essentially, we're all concerned. For instance, he mentioned populations around Lake Victoria, young men who disappeared. Uh, so they realized at that time that AIDS was not like any other infectious epidemic. It was an epidemic that attacked the economic development because the young people it was targeting was the future of the country. Those were young people who had a future, and they were the one, both male and female, were disappearing. So it was so important that something needed to be done. And the question is, will we be able to deliver? That was the question. And I think that we all felt something heavy on our shoulder because even though I was sure that it would succeed, you cannot be sure at 100% because you know that those medicines have side effects. People may decide not to take them, etc., etc. And I don't think that any of us at that time knew that it would be such a successful program. But would you try it? Yes, it was worth trying. Because at that time, there was nothing else. And for us physicians, particularly in the field that we chose, infectious disease, to have such a formidable enemy and not be able to do anything for so long, and then finally you have an arsenal that gives you a chance to fight it back. I don't think anybody uh, would refuse to try. And the experience we've had, all of us, was that we should plunge into it with all our heart, with all our might, and with all our effort. And I think that's what we all did.
So I can imagine you mentioned that you only knew Paul Farmer, you had not met Peter Mungani before. So I can just imagine being there and not meeting before to strategize. And then you asked this question, was there like a unanimous voice in terms of like what the response was? Because I guess that was I don't know if it was an ambush, which was intentional to see if you guys share the same sentiment and believe in what you're doing. Like, how did that work out? If you can explain, who answered that question first? Was it all of you? Like, if you can just go to that day, if you can recall as much as possible.
Well, with Paul, I'm older than Paul, and when he came to Haiti, he was a medical student.
Mm.
And he came to my place and get guidance. So we've been friends ever since. And we've worked with PIH all along for so many years. So Paul was like our organization in a rural area because we had the same vision of global health. Peter Mungini, Peter I didn't know at all. And he was coming with a totally different vision and totally a lot more experience than we had because he had access to the drugs much more than we did. So Peter Mungini had treated more patients than Paul and I combined. I think that by that time, I had treated 18 patients. Paul had treated 6 or 7, and Peter Mungini had treated 40. That's the dimension. And but we all realized that it was a historic moment, that we were on the verge of something big, but we could not tell how big because nothing like that had ever been tried in the world before. So this is why it was so formidable when we heard of it. And then as it continued, me, PEPFAR is really the example of an exemplary president who has put his feet on the fire because if it had failed, he would have failed very, very poorly. But he trusted us. And for having met him many times, I admire his humility and the fact that he's of those presidents who doesn't push you down, but instead he's the type who wants to raise you up. And what I've seen, what he's done for Africa, what he's done for my country, and for so many countries around the world. And this PEPFAR program is not only a success in terms of how many millions people it has saved, how many millions infections it has prevented, including children, how many people who are living well on antiretrovirals, but because it has strengthened system. It has strengthened the healthcare system of every country. For instance, if you look, and I think that would be interesting, look at the COVID experience. Everybody working in COVID is somebody who had a huge experience in PEPFAR.
That's true.
And also when the natural disaster came in, that terrible earthquake of 2010 that killed 300,000 people, the infrastructure that PEPFAR provided to us helped us cope with this. So we are hand in hand with the government. And it has created stronger alliance. For instance, I can tell you, Right now, our laboratory does half of all the HIV RNA tests that are done, and half the government does the other. So we work hand in hand with the national lab. So our lab does half of the test, they do the other half. So really strengthening our institution, also strengthening the surveillance system. Haiti, thanks to the CDC, may have one of the best surveillance systems for developing country. So because that system involves so many different institutions. Now, what didn't start well was the PEPFAR electronic medical program. We've been electronic. We have electronic medical records in our institutions for 35 years. So we don't use paper charts anymore. Everybody enter their own data, and it adds to the patient chart. So when you go to your computer and you enter that patient's number, you find what has been done, and you add yours, and the lab add theirs, et cetera, et cetera. So the PEPFAR program was far behind ours. So up to now, because ours was geared not only for care, but for research. And ours is more complete. So up to now, when we provide data to the PEPFAR program, we retrieve data from our system. Our system is large. But that's the way it's been going. But the transformation of PEPFAR, I think every American should be so proud of that program, because this is their passport to the world, because it's a program supported by the American people. And the US government understood it well when they created the post of ambassador, because the director of PEPFAR is a real ambassador, is the ambassador of whatever good the US has that it can provide to the world. And I think that this is this image that it gives of America, the United States of America, that's helping people survive with the most horrible epidemic that we've known.
Thank you, Doc. I want us to transition from that dinner with Fauci to now meeting Joshua Bolton and the Bush administration the next day. So you hear about this possibility of this something exciting happening. How do you now, the three of you plan for that meeting? Were you able to sleep? Did you have to scrounge around? What happened in the aftermath of that meeting with Fauci in that evening?
Well, we met in the morning, and we met with different people. I can't remember their name. I remember there was a woman was there. She was quite aggressive, asking us very tough questions. And Joshua Bolton was very nice. His only point was, and I think that was his job, to make sure that we could give him the proper answer. Are we able to deliver? And I think that it's quite fair, because if we were hesitant and if we were unsure, I think that it would have raised many questions. To invest 15 billion, I believe this is what it was early on, in a program, so much money, and then to be a failure would have been a disaster. But we realized the importance. We realized also that we became PEPFAR ambassadors for the program in our own country, that it could not fail. It had to succeed because it is too important. The life of people are hanging on the line, and we have to deliver, making sure that it can be done. So the meeting went back and forth, asking questions, etc. And I remember clearly that there were questions also about whether uh, with a single bullet, you could do the job. And I remember the lady said, well, our aviation in Iraq was able to win the war. And could antiretrovirals do the same to win? And we said, well, it's more complicated than that because we're dealing with people and they have different issues, etc. It has to be integrated in a well-rounded program. That's the only way it's going to work. We should be able to treat opportunistic infections, to treat TB, and to provide for prevention as well. Because if you're at that time, we didn't know that treatment was prevention. Nobody knew that. It came much later. So treatment was separate from prevention.
Hmm. Okay, so all of that gets to be threshed out, hopefully. And then what was the concluding message after that meeting with the Bush administration? Were you told to come up with a plan of action? What was the takeaway message?
Well, I don't think they give us, they told us what was
They
going to
just
be
grilled
done.
you and then they left.
Yes, yes. I think that they got the information. They were probably going to report it to their boss, and after that there were probably many more meetings before it ended up in the program announced as we know it. But when we left, and we talked to Tony after that, and Tony said he was going to push very hard, and that they were strong supporter of the program. Among them, Colin Powell. I turned out I had met him before, and because he's also from the Caribbean, he's from originally his family is from Jamaica, so we link immediately, and I saw that he was somebody very committed as well. I met Mrs. Rice also after that. So all people who were fanatics of doing something major for AIDS.
Okay. So the meeting is over. How did it feel knowing that there was this possibility to scale up provision of art? I mean, for you as a physician, for your people, did you round up together after the meeting, the three of you? And I mean, what was the atmosphere? What was the feeling thereafter?
No, we never met after that. We I met Peter McGinney much later. Paul Former, of course, we talk much more frequently, but we never discuss the outcome because we didn't know what the outcome was going to be. They left us hanging. I had probably more connection with Tony Fauci at that time, but even Tony was, he said, this is moving, but I guess there was a word in DC not to spread it. So they wanted to keep it secret until the announcement. So I think that very few people knew that it was going to occur and the actual dimension in the program.
And then, I don't know, months later, whatever the timeline is from that meeting, prior to the Bush administration, and then PEPFAR being announced. Were you there? Did you follow the State of the Union address when it was announced? Did you have some kind of, somebody like a whisper coming from Fauci that it was coming? I mean, because,
Yeah,
uh, for you
Tony told
to know, to hear it, you must have been following the State of the Union address, and I'm sure you were preoccupied with your patients in Haiti. Were you there? Did you get people to call you? How did it
yeah,
happen?
yeah, Tony gave me the head up. He said there is going to be this, and he did it essentially the day before. He said there is going to be this tremendous announcement, etc., etc., and that now you understand better why I needed you to be in DC.
Mm.
And obviously, it was great. We saw Peter McGinney with the First Lady, and this was such a moment of joy for all of us because you see, there is something about an idea that has not matured until it became the evidence that it was going to be given. And even during the State of the Union address, we were not sure how much every country would be able to do for their citizens, how it's going to happen, et cetera, et cetera. But it happened very, very fast. And I must say that this is, I can tell you, since PEPFAR started, even during the worst time in Haiti, epidemics, earthquake, we never miss one single drug delivery from PEPFAR. This was unbelievable. Their matrix, the way they organize it, it was superb. We never had anything missing. The Global Fund, we had very often drugs that were missing. We were able to talk to PEPFAR to compensate, etc. But over the years, I've seen Tobias was the first ambassador. I saw every single one of them. Eric Gooseby became a very good friend of mine. In fact, during the earthquake, Eric helped us get the U.S. team to Haiti. And then when Eric became ambassador, we are very, very good friends. So I know all of them, then Debbie Burks, and I'm also a member of the PEPFAR board, scientific board, advisory board. So it's been really a joy to work with PEPFAR, to see what it has done, and to show the world what one single president can do with a single program. And I think that everything else that is done in health will be measured by PEPFAR standards. Because PEPFAR has indicated not only the visible things that you see, people that have been saved, but it has improved the surveillance system, the health infrastructure of every single country. So it is the fact that it has married the health system in the country and made it so much better. So this is what it's all about. It's not just people, but it's standards, it's infrastructure, it's programs.
So PEPFAR is announced, and money needs to get out to serve as many people as possible. The issue of resources is struck out. It's time to deliver, and the promise that it was possible. So what changed in the way that you were arranging your care to your patients? Was there anything that you did in anticipation for the funds coming? Because there was a bit of process before actual funds came. So can you just explain how did you prepare for that, transition?
Well, let me tell you, it made such a huge difference because, as I said, 90% of our adult patients died in 1 year. We did 3 studies, all 3 published in the New England Journal of Medicine. We did a study on 1,000 patients who received antiretrovirals, followed at 1 year. 90% survived. We did the same cohort, we followed them at 5 years. 75% survived. We've published on the same cohort at 10 years, 70% survived. And the survival rate was comparable to what you had in the States. So no question that not only it could be provided, but it could be provided effectively. Although our patients were much more sicker, they were malnourished, we had the same outcome. So this was essential to promote antiretrovirals at the national level. So at that time, we already had a public health model. We just added antiretrovirals to it. And then, it changed the whole thing.
Your face really always lights up when you talk about this milestone because I guess because if it had been such it looked like an insurmountable challenge and then there's like a breakthrough, it just helps to, to be able to accomplish the purpose and the vision of DSCO. So the funds are coming now to Haiti. How do you become a partner, an implementing partner for the PEPFAR funds?
Well,
Were you a prime partner immediately, or you started as a sub? How did that work?
essentially, CDC run the program, Centers for Disease Control, and they are still running it. And the way it works is that all the sites that were global fund sites, they kept and they provided funding, comparable funding to the amount of patients that were being followed. So some centers got more because they were following more patients because they had more satellite sites. And what we did essentially, it was so effective that the CDC replicated that. What we did essentially is that we trained a physician at our sites doing exactly what we are doing. And then we put him at every satellite site, we put one of the physicians that we trained. So that physician knew everything we were doing. And if he had any question, he could ask us. So the CDC did the same. They put a CDC person at each site as well, so they could manage their program. So it worked really beautifully. And with the CDC, I must say, we've had an excellent relationship. It's been very nice. I cannot have I don't have any complaints about PEPFAR, not a single one. The only issue that I had early on was when it was concentrated on ABC. And we knew that for our country, ABC would not work. And I remember at a meeting that President Bush had asked me to be there, at that time, I met many religious leaders, and he asked me the specific questions. He said, Dr. Pape, could you tell those leaders why ABC doesn't work? And I had the painful reality to tell them why it didn't work. I'm not sure I convinced them. There was also the ambassador of Nigeria was there, a woman, and she tried her best as well. But it's difficult to convince people who have their own faith and their own beliefs. So I try to tell people the truth. The same I would tell my patients. And now it's for them to get it sink in their mind if they accept. But I'm not going to force something on anybody. You have to accept yourself until you're ready to accept it. And I think that now religious groups are perhaps more tolerant because they realize that it doesn't work as well as they thought that it would.
Hmm. Oh yeah. So I was gonna just follow up, like, if you had to say that it didn't work, like, can you give reasons why you thought ABC could not work, especially in the context of Haiti?
Well, essentially because AIDS is a disease of the poor, mostly in developing countries. And the poor is transmitted, we know, it's transmitted sexually. And young girls, they very often have to deal with people who can provide them for their food, for their school, etc., etc. And those older men will not want to have condom use, or the girl would not have anything to say. So it's a reality. Now, can you change it? Well, the only way you can change it is to, one, make sure that the girl is not dependent. So what we've been doing is, we know adolescent is very fragile period, we make sure that our adolescents, girls go to school or that they are involved in vocational work. So you keep them busy. But if they are not busy and if they cannot afford for themselves and their family, obviously they are going to fall into that situation. So it's a reality, it's an economic reality. And we have found the opposite also. When women work in factories, they are the one who have 4 or 5 men dependent on them. So it's the same type of relationship that is due to economic conditions in the country.
Mm-hmm. So basically, the triumph over reversing infections in Haiti, you would say it's predominantly attributed to drugs, using medicine. I mean, HIV drugs to be able to deal with that. There was not much of behavioral change that you could say contributed to that.
Behavior change, yes. For instance, we were able to promote condom, but we did it a smart way. In that we didn't force it on people, but we address it more on the men than on the woman, because the man is the one using it. If you cannot convince him to use it, then how can the girl impose the man? So we were smart, strategic in the way we use it. We told them that not only HIV, there are many other sexually transmitted diseases that condom can prevent. And I think that, if you want to have a good life, why don't you use condom? And then they were worried about whether it will be the same, et cetera, et cetera. And we said, well, try it and you'll see, give it a chance. So condom sale has jumped in Haiti related to that. So we tried everything. We did even abstinence. We tell people, we say, look, the best thing, if you don't want a car to hit you, never go in the streets. You can stay at your home. But that's what abstinence does. But can you always stay at your home without going in the streets? This is the situation. So the more you can use abstinence, this is better. Because we told the girls as well that human papillomavirus, which causes cervical cancer, and we work a lot on that, is also linked to promiscuity. And it's not just HIV that you prevent by being abstinence or by using barriers method. It's essentially a long host of infectious disease that later on can give you cervical cancer that could kill you. So it's a package, and you have to be comprehensive and address it as such.
So, can we talk about the PEPFAR funding, the first tranche of the PEPFAR funding? What is it directed to do? Or maybe before that, even like just becoming a PEPFAR partner, how did that happen? And then the first funding that you received, what was it directed towards?
Well, the partners are easy because they existed already. With the Global Fund, there were already a network of partners. So all we needed was to plug in antiretrovirals. So we just added antiretrovirals to our public model that just needed that. So it completed that part, and the partners existed. So depending on the number of partners that you had and the number of patients that you saw, you had a funding that was in adequation with that. So it's not complicated.
I'm sure your normal routine day changed from when you had fewer clinics providing art and when, the expansion through PEPFAR funding came in. So what was your typical day like, then when you had to have this massive expansion taking place, meeting with partners? What was it like going to different facilities to see how it's going? What was your typical day like?
Well, essentially, I mentioned earlier in the oral rehydration program, I had created mobile teams. So we created a mobile unit. The mobile unit is headed by a physician. It has nurses. It has laboratory technician. It has a social worker. So that team, the same way we did for oral rehydration, before we have a team using antiretrovirals, we had the team come to us to train. At the same time, we had them prepare a pharmacy plan, how they're going to stock their meds, how they're going to distribute their meds. Do they have a counseling unit? So we made sure that they had all the parts, the laboratory, the clinical part, the pharmacy, everything had to be in place. And they had to have outreach people, like community health workers that will go after that patient in their community. So it's a whole package. And we train them, and then we have our mobile team go and visit them every month. So each our satellite site is visited by our mobile team, but at that satellite site, we also have, as I mentioned earlier, a physician that we train who report to us constantly. So if that physician has a tough case, for instance, a patient who is not taking his meds or is not doing well, he's going to call us, and then we're able to tell him what to do. So they are not left alone. They are part of us all along until they graduate and can evolve on their own. So at that time, early on, we had, as I mentioned, 50 sites. It was huge. Now we have 60, so it's much more manageable.
So did you do any prevention work beyond just PMTCT
Oh
in
yes,
terms
oh
of
yes,
education, right?
oh yes, oh yes. We have a. You see, in our training program, there's a full program linked to prevention. Prevention at all levels. Prevention uh, of discordant couples, for instance, because this is really one of the biggest problems when you have one partner infected and the other one is not. How are you going to inform the other partner? Sometimes we have to be careful because if it's the woman who's infected and the guy is not, that he doesn't abandon the woman. So, all of those things are complicated, but we've been able to find ways to deal with them and to prepare centers and train them on how to deal with that.
So I know you mentioned that you had about 17 partners that you were working with. So was there like a coordination mechanism where you meet together? And I know that, through the trajectory of HIV treatment, it has been staggering. You started with the WHO treatment guidelines, 200 CD4 count, 350, 500. So was there a time where you would get together to adapt those guidelines? Where were the most milestones that you had to come together and meet and agree or have consensus about with the other partners?
Okay, I'm glad you mentioned about the CD4 count because the first CD4 count that the WHO recommended was less than 200. And we did a study that was published in New England Journal of Medicine where we took two groups of people, 350 who started at less than 200 and 350 who started at 350 CD4 count. And after the first year, the Data Safety Monitoring Board stopped the study because the group that started at less than 200 had four times more death and four times more cases of tuberculosis. So that have changed the WHO guidelines. The other thing also that we did very early on, we may be one of the few centers or only center in the world where if you come to us, we'll evaluate you for tuberculosis because we found that 30% of adults who are coughing and who come for an HIV test have actual tuberculosis. But not only that, we'll treat you the same day. That is somebody who comes just to have an HIV test, because we go through a whole questionnaire asking them their coughing, etc. We do the diagnosis the same day because we have gene experts on site that can make the diagnosis in an hour and a half and chest X-ray, and we put them on medicine. Why? Because if you tell a patient, in our experience, a patient who is not educated, that he has a serious disease, and then you don't put him on treatment, he will not come back. He will say, well, the doctor, he doesn't know what he's talking about. If it was so serious, he would place me on treatment. So we did the same also for HIV. If you come, you have your HIV test positive, we will place your treatment this very same day. And we found also that we did a study on that actually. People who started the same day and people who started 2 weeks later. The WHO adapted this as well, recommending same-day treatment. So it's been really magnificent and challenging and beautiful to be able to lead the way, not only in your country, but in the world, and be able to save so many lives. But all of this is thanks to the generosity of the American people, led by a unique president. That's the way, and that's why, I would be on my deathbed. You would ask me to do this interview, I'll do it, just to give this special recognition to that special person.
This must be the highlight also for me doing this interview, just learning in granular detail how much the HIV program in Haiti has helped to shape even what we call the WHO HIV treatment guidelines. Because as you were saying that, I was like, that's test and treat. It was there already before it was like in the guidelines. Because Haiti is now, I know it's the one that contributed to getting that scientific finding and hence informing that pathway towards HIV treatment. So quite remarkable. Cannot be pleased that, I have you in front of me. I just wish you were here in person, but, yeah, so that's really remarkable. So we have spoken about the meetings with partners. I think let's just move along. So PEPFAR's model could include sub-partners. Did you have any sub-recipients that you were
Yes.
working with? And what sort of criteria did those partners need to have? And
Well,
how do you manage them?
essentially, as I said, we train them. And
Mhm.
we even train them in administration and accounting. So twice a year, the administrator and accountant, because the funds were given to us, we are accountable for the funds that we give to a partner. So we have to make sure that they do the right thing. So twice a year, we have the head of the program, the accountant, the administrator. They come to our place and they get a full training on standard accountability practices, financial practices, etc., etc. So that part is very well covered. But the same way, the clinical criteria are also presented to them. Whenever there is some new research, we bring them in. And they are fascinated as well because they see that we are moving along very fast and they are very happy with the pace at which it's going. And it's been going very, very fast.
So I want to move now into the practicalities of having, receiving the funds from PEPFAR. As we have spoken with other implementing partners elsewhere, for some it was really a big change. So I want us to talk about how was that process? Because there was a lot of data demand that was needed to report and, informing PEPFAR what was really being used for these resources. Was it a very drastic change that you had to incorporate so that you meet the reporting guidelines and data that was required by PEPFAR, or you already had a system in place and it was not a lot of change to incorporate that?
Very easy for us because everything was already incorporated. In fact, up to now, when we report to PEPFAR, we have to extract data from our system because our system is more complete. So we extract data from our system to give to PEPFAR. So it does not be the problem at all.
So, which funding was it that enabled you to be able to put this kind of system in place prior to PEPFAR?
Essentially, we are very talented people, uh, engineers in data management. The other one created the program, and they created it to exactly our needs. So it was tested here, and every time we had it, I remember our program was in DOS, and we had an expert from Vanderbilt University come in, and he said, "Wow, it's a solid program, and but you'll have to change it at some point to make it go faster. You'll have to switch to Windows." So we made that transition over a 3-year period. We transitioned from DOS to Windows while keeping both programs, and it has worked very, very nicely. So we're very talented people who are invested in this, and it's evolving at all times because every single study we have, let's say outside PEPFAR, we have an electronic medical system that help us run that study. For instance, our system right now, because our downtown system, our downtown center, let me explain how we work. We have 2 large centers. One where I'm sitting now, which is close to the US Embassy, not far from the airport, and another one which was much larger, and that's where I used to be, in downtown Port-au-Prince. But the one in downtown Port-au-Prince is exactly within 10 meters of the largest gang in the country. Now, that gang, as I mentioned before, didn't prevent us from working. But because there was constant exchange of fire between the police and the gangs, very often we had bullets in our offices and in our waiting rooms. So that's why we had to split that center. The center is still functional. It's functional at 40%, and 60% are seen in 11 community centers I set up. And I set them up near patients' place of residence. So patients, even, let's say, there is a strike, they can walk to that center and get their medicine. But all those centers also have that electronic medical record. So I can now, from where I am, look at every patient admitted to any one of those centers to know how many men, how many women, how many children, how many have tuberculosis, etc., etc. So and if one patient who is sitting here at my place want to go to any of those sites, it's compatible. They can go. They will be seen, and we will know that they are seen. So it's a very, very nice system that made life much easier for us, and is working very, very nicely.
So let's fast forward 4 years after the announcement of PEPFAR. Funds get out. It helps you to augment the already existing programs in Haiti. And you have that invitation from President Bush in 2007 that was marking 5 years post the announcement of PEPFAR. So what did you see as the highlights and the weaknesses of the PEPFAR program at that 5-year mark?
Well, I think that at that time, the president knew the program was working, and he wanted to know how things were in Haiti, how things could be improved. And I saw that it was a president who was satisfied with the tremendous effort that the US was doing and was happy to see so many lives being saved, but at the same time, an ambitious president who didn't want to stop there And he asked, what more could we do? And we discussed mother to child transmission, et cetera, so that the program could be expanded. And he was totally open to do more. And clearly, it was a huge encouragement to see that he was not complaining. In fact, he wanted us to move faster. And I was amazed at his humility also. Uh, the fact that he didn't take credit for it, as if he was any other president who was sitting there and found this program created by I don't know who, and just wanted to make it better. How can it be better? So, those are things that make you happy to see that there are people in this world who want to make things better for others, whether they are from the same religion, whether they are from different ones, regardless of their skin color, their background, etc. He believed in humanity, and that makes us only feel good because for us, our job is to help people, particularly the poor people. When we see others moving in that direction, it gives us confidence that the world can be a good world.
And of course, he had the press conference, and you're standing behind the president, and he was delivering this successful program, of course, with view of reauthorization. How did it feel to be part of that moment?
Well, it's a moment in history. I felt that, well, maybe I contribute a small part, tiny part, but even if it's a dime in a $1 trillion intervention, I'm glad that we did it because our mission as physicians is to help others. And this program help us not only to save lives, but give hope to people. Even others that we could not save, we give them hope to live a better life.
And a year later, the First Lady comes in person to Haiti. You had to host the First Lady, Laura Bush, in 2008. Tell us, what was it like having it, and the events that led to her wanting to come to Haiti in person?
Well, I think that she's very much invested in mother-to-child transmission, in particular, as a mother herself, and very much invested in education as a teacher. So she wanted to see with her own eyes how people in the field were working. And we were delighted to receive her because obviously they say behind every great man there is a great woman, and I strongly believe that. Uh, we were delighted to see her. And in my institution, I can tell you, 60% of the institution is run by women. Women are very strong where we are, and they are the foundation of what we do at GISCO. So they are really, I am the minority. The majority of the people running the program are women here. So she felt right at ease, seeing many more women doing things that are right for the poor people of Haiti.
I think one of the things you've taken from esteeming the President Bush is the humility, because you've done so much, but you want to remain at the bottom ranks of that. That's okay. It's a subjective discussion. I don't think so, though. Uh, have you followed the different American presidential administration as far as reauthorization is concerned?
Yes,
Post-President Bush, and if you can
yes,
just tell us about that.
yes, we have, and we were happy to see that there was bipartisan support for this program. And again, I think that to me, I'm not involved in politics, but I think that when politicians see something that works uh, and that has such tremendous impact, whether you're from the right, from the left, or from the middle, I think that you're a good politician if you're able to support that, because at the end, it's the life of people who are hanging on the line. So with the Clinton administration, it worked well. It worked well with the Obama administration as well. We were able to move on. Each time there was no worries. With the Biden administration, we had, I'm a member of the Institute of Medicine, and we met at the Institute because there were issues as to whether some people were tired of AIDS because there was so much progress and there were so many new problems in the world. And I can tell you, for instance, what's fascinating. I told you early on when I came to Haiti that infectious disease were the leading cause of mortality. Now, AIDS represents only 5% of all deaths. It used to be the number one cause of mortality for 3 decades. It's only 5%. 30% now is due to cardiovascular disease. My AIDS patients are not dying of HIV, they are dying of cardiovascular disease. So this is why we opened the largest center in the country for cardiovascular disease. And the beauty about it is to see how infectious processes are associated with chronic disease. Because what we have found is that patients with HIV are more likely to develop hypertension. And hypertension is the leading factor for cardiovascular disease. So again, we are talking at some point of merging prevention and treatment. And we need to merge infectious and non-infectious together, infectious and chronic disease together, because at the end, you're dealing with one person, a patient who may have both. And this is the beauty about it. And that's why now a lot of our work is on cardiovascular disease, whether the patient is HIV infected or not.
So, not only did you host the First Lady, but in 2010, the president himself came to Haiti in the wake of the hurricane. Will you just tell us about how this happened and what did this visit mean to you?
It meant a lot. As you may know, we had this terrible earthquake in 2010. And the same year, we had our first cholera epidemic at the same time. So it was and it was the worst earthquake in over a century. It was the worst cholera epidemic over a century. A small, tiny country with small resources having to face both. And we're in the middle of both because we worked very hard during the earthquake to receive earthquake victims. We opened a field hospital to receive people who were wounded. And the same, we opened the first cholera treatment center in Haiti. Every one of our centers had a cholera treatment center. So we are very much involved. And you know that President Obama created that foundation that they call the Clinton-Bush Foundation to help Haiti. So it is a context of that foundation that both President Clinton and later President Bush visited Haiti again. So we are delighted to see him. He came with his daughter. And we are delighted to show him what we have done. And it's with that support that we extended our vocational school. Vocational school that we had was dedicated to construction workers because we knew that we had a country that was destroyed and we needed to train people to rebuild that country. And as soon as they graduated, they found work. So it was really beautiful to receive the president to show him. At the time, we had 9,000 people who were internally displaced that we had to provide for, women and children. And the beauty about it, we didn't have one single death. Those people stayed with us for 5 years. We gave them the best of care, immunization. We even had 900 women who gave birth. Not one single patient died. So that helped us create a model for how to provide care to internally displaced people. And this is what we're using now for internally displaced people by gangs in Haiti. So it's one thing leading to another. And when you do your homework, you know that you're going to use it for some other calamity somehow. And it's experience building one on top of the other.
As we conclude your professional experience with PEPFAR, I just would like to ask, what were your proudest moments working for this program, working in this program, and with this program? And of course, some of the challenges that you have encountered, and what would be done differently, in hindsight, if you do some contemplations about the program.
Well, honestly, as a physician, you want your patients to live. And the beauty about it is when my patients came in and asked me for jobs. They said, Doc, I'm well now. Can you help me find a job? You know, this is so beautiful because you have somebody who was almost dying and you're able to revive not only his life, but give him hope to the point that he's asking. And that's when our global health program became more relevant because we realized that in a poor country like Haiti, it cannot be dependent on health alone. We need to add education, economic opportunities, potable water. This has all to be linked together. So this is my proudest moment, is when my patients were asking me for something more. Now, the only frustration with PEPFAR was with the electronic medical record, because it was at first totally inadequate. It didn't respond to the need. It only met CDC requirements for what they wanted to monitor, but it didn't help you to follow the progress of the patient. Because, my program, I can see from day one how the patient is moving forward. I've all his tests. I can see that his CD4 count has improved, that his viral load has turned negative, etc. You could not tell that from the PEPFAR electronic medical record. So it was a problem also because when we were working with partners, they had the CDC program, but they could not tell how the patient was progressing based on that program. So this is the only thing I would do differently, is have an electronic medical program that was adapted to the need of the country, not just the need of CDC.
So we know that initially PEPFAR had sustainability in mind, because if you're in a development program, you always have to have that in mind. And it was one of the key goals of PEPFAR to do that with the partnership framework, the implementation plans that were there in the beginning. Could you just explain to what degree was GESCO able to do that, or what was your vision as far as sustainability is concerned? Because we know if it's funding, you cannot always guarantee that it's going to be there. How do you deal with that?
Yeah, that's been a problem because you see, in the last 30 years, it's been very frustrating because Haiti has been going down the hill. And in particular, I would say the last 7 years, we've had an economic downturn with negative GDP. How can a country sustain 7 years in a row of negative GDP?
Mm.
So what has worked nicely is the fact that we work with HIV-infected associations very, very closely. In fact, many of them house our patients who are treated for HIV/AIDS. They are taking the lead. And in fact, on December 1st, we'll be pushing the government to put some money into this program. Now, I know that it's difficult for them because they are in a terrible financial situation, but at the same time, they need to realize that you cannot be dependent all the time. And those HIV/AIDS associations are leading the way, and we are helping them push forward. So I think that this is the way that I think it will happen, and I think we will succeed.
Can you just also explain to us what changes were there and the impact that has been there since January of this year when there was that order to stop funding or limit funding? I know that there's been change from January up to now. Where are things at? What has been your experience in Haiti as far as that's concerned?
It's been difficult. It's been difficult because we are told by CDC one day, stop working. And obviously, we could not stop. How can you ask a physician not to see patients? So obviously, we continue working because we could not. If a patient comes to me, my job, even if he's my worst enemy, I have to see him. And as patients came in, we continue seeing them, even during the period where we are asked to stop. So we didn't ask anything for PEPFAR, but we continue seeing our patients because this is our duty, our responsibility.
Mm.
And then we are told on a Sunday, abruptly, show photos that you started working again. So that was just, totally crazy, but we said, okay, no problem with that. We showed photos, and then things have evolved gradually. They mentioned to change some names, etc., which we did. But all in all, our budget has been cut about 40%, but we are managing because it's our job to manage. It's our job to provide for our patients. We are grateful, and I tell my staff, look, even if the complete funding was to stop tomorrow, we're grateful that we've been able to help so many people. So that's the way we should look at it.
I didn't realize I was in the picture.
That's why I'm just turning it so you can show for
Yeah.
anything you want to say?
I say this has just been wonderful, Dr. Pape. Truly, hearing about all the amazing work you did has really been great. Thank you.
Thank you very much, and thank you for all you're doing. And this is one part of history that needs to be remembered because everything will have to be compared with PEPFAR. Everything that is done in medicine and beyond medicine, because we said, why can't there be a PEPFAR for education? How can there be a PEPFAR for sports? Everywhere. So PEPFAR is a standard that will remain forever. Thank you so much for what you're doing. And I'm so glad that this will stay for history to remember because we need the young generation to know that hope exists and hope can be created and hope can lead to such great things. Thank you so much.
We share that sentiment. So thank you.
Thank you.
Yeah.
Bye-bye.
Yeah.
Okay. All right. We
Thank
will be
you
in
for your
touch.
time.
Thank you so much.
My pleasure.
Bye-bye.
Bye-bye.